Hello and welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor of JAMA Network Open.
I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along, please reply to us and mention at JAMA Network Open on Twitter, or just ask questions or comments in the comments under the video, live streams in Facebook or YouTube. We'd love to hear your thoughts, get your input, or you can make fun of my clothes. So our first paper today is the effective mailed HPV test kits versus usual care reminders on cervical cancer screening uptake, precancer detection and treatment, and RCT. And we've got first author, Dr. Rachel Weiner, here with us. Welcome, Dr. Weiner.
For having me.
Great. Really glad you could join us. So why don't you tell us a little bit about yourself and the reasons why you did the paper and what you did?
Sure. So I'm a professor of epidemiology at the University of Washington. I also am an affiliate investigator at the Kaiser Permanente Washington Health Research Institute. And this trial was a collaboration between University of Washington, Kaiser Permanente Health Research Institute, as well as investigators at the University of Texas Southwestern Medical Center and the University of California at Davis. And my research interests are in human papillomavirus, or HPV, and HPV-related cancers, such as cervical cancer. So we were really interested in evaluating strategies to increase cervical cancer screening in U.S. women. We know that Pap screening programs have been very effective over the past 50 years in decreasing the incidence and mortality of cervical cancer. However, under-screening is still a problem. So even though it's available, about 25% of U.S. women who should be getting screening are not getting recommended screening, and they're really a high priority population to target to get screened because of the 12,000 cervical cancers that are diagnosed each year in the U.S. We know that about half of those are in women who are either overdue for screening or never get screened at all. And this is even true in fully insured populations where about 1 out of 4 women are not getting screened. There are barriers that we know of, including inconvenience. It can be difficult to find time to get to a clinic, difficulty taking time off of work or finding childcare, as well as just negative experiences with pelvic exams. And so in the US, there's currently 3 options for cervical cancer screening for women in the 30 to 65-year age group. There's the traditional Pap test. There's also what's called a Pap and HPV test. So where in addition to the Pap test, they're also testing for HPV, which is the virus that causes cervical cancer. And then there's a new option that is now available per 2018 U.S. Preventive Services Task Force guidelines, which allows for an HPV-only screen. And these are all clinician-performed options, and the goal is always to detect cervical precancers before they have the chance to progress to cervical cancer. So with HPV-only screening, it's an exciting option because we know that a test collected by a woman herself, a vaginal swab, performs just as well as a clinician-collected swab for detecting HPV infection. And in fact, there have been many trials in other countries that have organized screening programs where they tested mailing HPV kits to women as a strategy to increase participation in screening. And it was very effective in increasing screening participation. And in fact, some other countries like Australia and the Netherlands now have these options for overdue women. So what we wanted to do is, this had never been tested before as a strategy within a US healthcare system. So we wanted to see how well a strategy of mailing kits to women who were underscreened could work to increase screening uptake. So what we did is, over 2.5 years, we used the electronic medical records at Kaiser Permanente Washington, and we identified about 20,000 women who were overdue for routine Pap screening, 30 to 65-year-old women, and we randomized them to one of 2 arms. The first was the control group. They received usual care, and at Kaiser Permanente Washington, that consists of annual preventive services reminders that they were due or overdue for Pap testing. The other arm, the intervention arm, they also got the same usual care, but in addition, we mailed them an unsolicited mailed kit that they could use to collect their own sample at home for HPV testing. This was a pragmatic trial, so as much as possible it was embedded within the health system. We tried to mirror as much as possible the strategies that the health system would use for this sort of approach if it were to be implemented. So if the woman decided to do the kit, she would collect her sample, she'd send it back to the central laboratory for testing. The result would go into the electronic record, and it would be followed by her own primary care provider. And we track screening uptake for 6 months, and then we also track detection and treatment of cervical precancers for another 6 months each. And basically what we found is that women who were mailed the kit, they were more likely to get screened for cervical cancer than women in the control arm. So 26% of the women in the kit arm were screened versus 17% in the usual care arms. That was a 50% increase. We also found that not only did more of them get screened, but the time to screening uptake was faster in the intervention arm versus the control arm, and that was in figure 3 of the paper. So basically, it was about 80 days to screening for women who either were in the control group or they came in for screening with a PAP versus about 37 days for women who screened with a kit. Now, actually, our primary outcome was not screening uptake, but detection and treatment of precancers. We wanted to follow the complete continuum from screening to detection to treatment. And actually, we did, even though we detected a few more precancers in the intervention versus the control arm, it was not a statistically significant increase.
And that's one of the things that I think impressed me the most about the study, not the findings, but that you actually set the bar high to actual detection and not just completion of the protocol, which is great. Quick aside, welcome Ahmad Osman and Pam Anderson, RN, who've joined us. So welcome. We're talking about a great RCT on home HPV screening. And again, I think there's so many things about this study that are just like so nice. RCT, 20,000 women, a very real world control group of usual care. Yeah, it's really pragmatic. I also love studies where both groups, the intervention and not, are getting a good effective treatment, and it's not just like, oh, we're not, I don't know, not doing reminders, or whatever it is. And you were talking about many of the different barriers to screening. There's so many, and I think one of the things I found really interesting, and it's also, you can see it in figure 3, that there was a big uptick in the curve of women who used the home kit for screening, but also a lot of the difference was just women who then went in for their regular PAP. Basically got the usual care themselves, and I think so much of it, I'm curious, and we see this in a lot of the behavioral econ stuff that we've been talking about, where it's just like, just getting the mailed kit is also just the nudge to do the other thing, even if you're not going to do the other stuff.
Right, it's like a second educational prompt in addition, because they all get, in this health system, they get a letter around the time of their birthday that tells them what services they're due for. And so, yeah, I think you're right, even for the women who maybe didn't do the kit, it was a second reminder of, I should probably go in and schedule my PAP test.
Mm-hmm.
Yeah. I'm wondering, so it seems like, these home-based sort of self-sampling kits may be a really great tool. I know this wasn't the primary outcome, but even still, it may be a nice tool to engage women that may otherwise be missed. Do we know anything about user variability in terms of being able to use these effectively and getting good results from the tests that can be used?
Yeah, that's a good question. So, many different studies in different populations of women have evaluated feasibility and acceptability of self-sampling as well as performance, and as well as with different devices for collection. And I think, what we've found is that it's pretty straightforward and simple for women to use with minimal instruction, and not much difference in, if you're comparing a self-sample to a clinician sample for HPV detection. There's not much you can do on the user end to, negatively affect the results. So hasn't come across as a concern.
Yeah, that's good. Yeah, if nothing else, you didn't show lower rates of finding finding precancerous lesions, which is good. I think that's nice.
Yeah.
Oh, one of the co-authors, Diana Buist, I'm sorry I'm mispronouncing her name, has joined us too. Welcome. We're talking about your paper. I guess I don't need to explain what it is.
Just going back to the kits again, I find this topic really interesting. Are these kits readily available, or are they still something that you have to get through a primary care provider or an OB-GYN or whomever?
Yeah, that's a great question. So right now, this is really a research-only strategy. So I mentioned that other countries are using this now for underscreened women as part of standard care. It's not yet standard care in the U.S., but we're really hopeful that with the change to the U.S. Preventive Service Task Force guidelines, where now there is an option for an HPV-only test, that this really could eventually become a widespread option for women, because previously the only strategies involved Pap testing either alone or with an HPV test, but a woman cannot collect her own Pap test, but she can collect her own sample for HPV.
And again, trying to address all the barriers to screening, I think it's fascinating, especially, if you've got childcare issues or transportation issues, those aren't necessarily going to go away with reminders. So if it's something that can be done without a visit to the doctor's office, that's great. I had another question, but I forgot what it was.
Well, hopefully this will be another, another nudge to help this home-based sort of self-sampling become more widespread or more available to women. Because I really do think, exactly as you said, there are all of these barriers that make it hard for women to get these tests. So that's great to see, and hopefully in the near future.
Well, again, great paper, really interesting findings. Thanks for joining us today.
Thank you very much. I appreciate it.
All right,
Bye.
great. All right, take care. We're going to move on to our table of contents rundown. Angel, start us off.
All right, so this is the association of Chorioamnionitis with Bronchopulmonary dysplasia among preterm infants, a systematic review, meta-analysis, and meta-regression. I don't think I've thought about bronchopulmonary dysplasia since medical school, but it is definitely a pathology of concern. And so this study wanted to try to examine an association that's been posited between chorioamnionitis and BPD in preterm infants. So they looked at or included 158 studies. This had 244,000 preterm infants. Of these infants, about 20,000 had chorioamnionitis or were exposed in utero, and then 24,335 had bronchopulmonary dysplasia. What they found were that chorioamnionitis was significantly associated with BPD both on postnatal day 28 and 36, but that association may be modulated by respiratory distress syndrome as well as gestational age, and that you can see in figure 4. There was also, I thought this sort of interesting, a significant difference between chorioamnionitis exposed individuals and unexposed in sort of both gestational age, birth weight, and early and late onset sepsis. The caveat with all this being is that the study was limited by the fact that there was significant heterogeneity between the studies that were included. But still, I think pretty interesting to think about. This is something, I think, at least my understanding of this is that we're still trying to understand the pathogenesis and how all of these things are connected to each other. And so this is potentially one more thing to think about.
Right. Yeah, absolutely. It's really fascinating. Also, I always love, I don't think I've seen a meta-analysis of 158 papers in it before, which is really impressive, and nearly 250,000 participants in it. That's fantastic. Yeah. I'm not going to pretend I understand what multivariate metaregression analysis with backwards elimination and how that modulated RDS. But yeah, it just kind of makes sense that chorioamnionitis, so infection of amniotic fluid, right, leads to some sort of lung not growing well problems. Yeah. I mean, there's probably inflammation. Inflammation's really hot right now.
Yes.
Makes sense. But it's just interesting to me that the association was kind of inverse with respiratory distress syndrome.
Yeah. I don't know. I'm not sure if it was that's easily explained,
Right.
or
Sure.
at least not by me.
Right. Not by us who don't study these social things.
Yes,
Right.
exactly.
Right. That's okay, but fortunately, there are great people who do.
Yes, exactly. So
Right.
thank you.
All right, great. So shifting gears a bit, so this is an interesting research letter that looks at access to care among individuals who experience Medicaid lockouts after premium non-payment. So this gets a little wonky, but Wisconsin is one of the states that used an 1115 Medicaid waiver where basically they got permission to charge premiums to certain types of people in Medicaid. Basically, people in Medicaid who make enough money to not be in Medicaid anymore, but are caregivers, like parents or caretakers of family members, get basically this transitional medical assistance program. So it kind of expands the Medicaid. And Wisconsin got permission to charge them premiums, basically make them pay for part or all of that Medicaid services, like a non-public insurance, essentially. And then, so in this paper, they did 2 surveys asking both people who were in this. Oh, sorry. And then if you don't pay your Medicaid premium that you're supposed to, then you're locked out of getting Medicaid. So you get this Medicaid lockout. You're not allowed to be in it for some period of time. So what they found, they did surveys among people who got in this Medicaid lockout, but presumably still make more money than they would to qualify for Medicaid, and compared them to people in the surveys who just had, I think were in the regular transitional Medicaid. Yeah. And basically, not surprisingly, they found out that they were more likely to be uninsured, more likely to forego receiving needed medical care in the prior year, more likely from 21 versus 8% of having fair to poor health, twice as likely to owe money, 64% versus 31%, and to need to, again, similar levels of needing to borrow, skip payments, et cetera. Had reported similar levels of health and working disability, but not surprisingly had these worse sorts of access to care issues.
Yeah, it was really interesting, and I'm hoping that you can tell me a little bit more about.
Sure.
It's not going to be a deep dive, but just about the whole concept of lockouts, because I wasn't that familiar with it. Is this something that it seems like it's a state by state thing, and I'm assuming that the thresholds are different, or as far as we know, or. Well, it's unclear.
Yeah, so I'm not an expert on this topic, I'll be honest with you, but with Medicaid, so in general, Medicaid is this joint federal state program for insurance for poor people, as opposed to Medicare, which is insurance for older people and is federal. The transitional medical assistance program is for people who kind of their income goes up high enough so that they don't need Medicaid anymore or they don't qualify for Medicaid, but then they're a caretaker, so they kind of have a dependent, basically.
Right.
But basically, the lockout is if they don't pay their premium, then they're basically barred from the program for a while.
Right.
And in some ways, it's, to me, one of those things where it doesn't make sense because basically, if you don't have enough money to get insurance for being poor, then you get punished for being too poor, and don't get support for being too poor. There a lot of politics goes into this, and I don't know. It's hard for me to explain more without being impolite in politics on that one.
I guess I was just sort of trying to just understand, whether this threshold is, how arbitrary it is, I guess. But I guess that does get that's
what I think. What ethicists would politely call a value judgment.
Exactly.
Yeah, exactly. All right, so moving on. Welcome, Fiona Russell. We're in a table of contents. Welcome for joining us. Next up, we have an interesting RCT, bimodal release Ondansetron for acute gastroenteritis among adolescents and adults. So this is an RCT. They had 321 patients who were at 19 EDs and 2 urgent cares, 2014 to 2017. They included everyone who's 12 and older who had an in-string diagnosis of presumed acute gastroenteritis. So fewer than 36 hours of symptoms, but in the previous 4 hours, at least 2 episodes of vomiting. And then obviously no other diagnoses like appendicitis, et cetera. And they got this novel formulation of the regular old Ondansetron, where it's this bimodal release capsule where 6 milligrams of Ondansetron gets released immediately, so kind of a nice big acute dose, and then another 18 milligrams gets released slowly over the next 24 hours, with the idea being you get basically like a bolus and then a continuous drip for 24 hours. Still the same drug, still Ondansetron. Their primary outcome was treatment success, which they defined as 24 hours of no vomiting, no need for rescue medications, and no need for IV fluids. And basically, they found an improvement. I think it was 66% versus 54% treatment success. Couple slight differences in some of the outcomes, slightly worse potassium, slightly some higher level, more patients with higher levels of creatinine.